Welcome to an AOT for Allegheny County webinar. I'm your host, Ruth Johnston. I'm a writer and a mother who lives in northern Allegheny County. Treating severe mental illness is not a fun topic, but it's my topic because a little more than 10 years ago, my oldest son developed paranoid schizophrenia on top of the high-functioning autism that we already knew about. Because of legal barriers to getting him into treatment, we were not able to prevent a tragedy. Pennsylvania law let us down first when we could not force him into treatment against his choice, and second, when it then sent him to prison for 20 years. If you want to read about what happened in my family, you can go to www.aot for Allegheny County. That's for spelled out like a word, not a number. AOTforawlleghenycounty.com, where I tell this story and more. Pennsylvania law now allows for an option for a civil court order to mandate medical treatment. But because every county has to opt in on the law and design a program, no county has yet done that. So there's no place in the state where you can yet have a civil court order. I want Allegheny County to be the first county to opt in and help families find treatment before tragedy. Today, I am talking to 3 social workers from Allegheny County Police Departments. We have Mary Bauer, and I think I'm going to remember what department you guys are from, but you want to just introduce yourself so I know you'll get it right. Mary, what department are you from?
I'm with the Borough of Sharpsburg Police Department.
Okay, okay. And Jalen
I,
Byrd.
yes, I'm with the township of O'Hara.
Okay, great. And Alyssa Peters, you're with,
I'm with Millville Borough Police Department.
right. And all of those they're basically suburban, they're a little bit urban. Nobody's, of course, we don't have anybody from downtown, but you have a pretty high density population in those. Yeah,
Yes, ma'am.
yeah. So just to start out, I am interested in finding out more about what social workers do in a police department. I mean, as just an average citizen not knowing anything, I would be aware that, if the people are arrested in the middle of the night and they have little children, you see if you watch footage of an arrest or something and you see people coming along and coming and helping with the kids. And that made me realize, okay, yeah, there are people like that. Do you get those calls and what other kinds of things do you do in the course of a week?
I personally haven't had a call, sorry, Mary,
You're good.
where we
It's
kind of
fine.
had to triage kiddos and stuff in the middle of the night. A lot of what I do is more substance abuse based or mental health based. People might be experiencing like psychosis and it's concerning people around them. They're noticing odd behaviors, stuff like that.
Yeah, and
Okay.
just to go off of Alyssa, we also kind of operate a co-response model. So a lot of us are going out with our officers. So oftentimes officers have a partner that's another officer. For our departments, their partner is a social worker. So we're getting calls to domestic violence situations, mental health calls, domestic violence, substance use. And we're able to immediately work with that individual and follow with them
Mhm.
until they get a long-term case management and service. But we're right there, boots on the ground, helping them immediately when that situation arises.
Is that the same with you, Jalen?
Yes, and just to follow up, even if it's during a shift that we're not working, the officers are obviously free to call us, and then if they're on scene, we can kind of walk them through a situation, or if someone is having any type of mental health concerns, we can then help walk our officers and helping them understanding, okay, what's the process to maybe potentially get a 302 or what have you.
Okay. So is it fair to say that, I mean, it sounds like a really high percentage of times when you get called in, there's at least some kind of, as you say, domestic violence. Do you usually end up dealing with essentially some kind of psychiatric issue? Is that pretty common?
Yeah, I
Yeah,
would say, oh, sorry guys.
good.
I'd say a lot of things that even if they don't necessarily come in as a mental health call, mental health is underlying it in some way, shape, or form.
Got it. Yeah, exactly. Exactly. So then you guys are called on to really be able to recognize that and immediately start talking about how to handle it so that it doesn't escalate. Is that a lot of it?
Yeah, and it's a nice partnership between us and the officers because officers are trained in one specific way and we're trained in another way. So we're able to work together to figure out the best solution for that
Yeah.
individual.
How many police departments in Allegheny County have people like you? It's not
So
most of them, right?
there's
Maybe,
not most. So it's
yeah,
easier if I just name them because I'm bad at math.
yeah.
So us three, there's two social workers in Hampton, one
Uh-huh.
social worker in Ross. Butler County has one that's in Cranberry. Baldwin Police Department has one, and Mount Lebanon has one. So there's like 7, 8 of us, 9 of us.
Okay.
And that's it.
Wow. Yeah, I know when police would come out, called for things with my house, they didn't have a social worker, and I think it probably would have gone better if they had, but there's got to be more work than the number of people can ever manage to keep up with.
We're busy, but that's
Yeah.
good because the people need it.
They do. They really, really do. They really do. Um, so what's kind of a typical call when I don't know, walk me through what the kind of thing you would often get, and at what point, you become engaged with it and start kind of directing it. Is it, I guess it's typically, as you say, well, it could be anything, not violence. Like, do you get called for like a suicide attempt when 911 calls? You get a lot of that. That must be really hard.
They're definitely emotionally taxing, for sure.
Yeah, we get calls for everything from an active suicide attempt to just suicidal ideations to a neighbor thinks their other neighbor is acting strangely, which turns into a mental health call,
Right.
to we get calls for overdoses, kiddo involved situations. We really don't have a limit on what type of calls we assist with.
Right.
Yeah.
And then depending on which, jurisdiction you're at. Like for an example, in O'Hara, we have a higher older population, older adult population. So I personally get a lot of, sometimes elder abuse calls, a lot
Okay.
of onset dementia, which obviously there's some other underlining issues with that. So just depending on our jurisdiction, we kind of have our unique calls, I would say.
The unique thing is too is that now that our officers have us as a resource, a lot of times the call isn't necessarily pertinent to us, but an individual lets the officers know, like, yeah, I've really been struggling, and it might just be an auto accident, but like, great, another stressor, I've been really struggling, and then the police like, cool, we have a social worker. So now I have technically an auto accident report referral, but it's actually mental health or high stress related. Or other things that you might not typically think, like theft, and then the police find out, well, they're actually hungry and low income and can't afford food, and then
Oh, interesting.
yeah.
And then that would be a great example of where you would remain engaged with the situation after the officer is no longer involved. Is that fair?
Mm-hmm.
A lot of the times we stay involved long after the officers are gone. So
Yeah.
the difference between us and an officer is they go, they deal with the situation, then they leave. We
Right.
go, we help with the situation, and then we keep them on as cases, as clients until they're stabilized and until we can pair them with a long-term solution, a long-term resource. So we really walk with that person in every step of their journey.
Yeah. Yeah, I'll say. So that could be days or it could be weeks. What's the longest you ever remained engaged with a case, each of you?
Oh, I'd say that really depends per person, per case. I mean, some
Okay.
some will be closed out in 2 weeks, easy peasy. They wanted a therapist, we got them one. They met them for 3 sessions and felt like they were doing great and stayed on it. I never need to see them again. And others, it's 3 months or more, and I think they're closed out and something happens, or it can be any number of things. Yeah.
Have you ever stayed involved as much as like a half a year or a year?
Yes.
I have.
Oh,
Yeah,
yeah.
I have.
Oh yeah.
You're all laughing.
Yeah, I have a client I'm going on 2 years with. So it's very individually based on what their needs are, how much support they need. Um, we offer like not every client gets the same thing. So it's a very individual based
Right.
service.
And to even go off of that, sometimes you go in there and you're helping one individual, but you come to find out that the entire family, the system as a whole, needs some
Yeah.
help. And so sometimes you go in and then you're expecting to help this one individual, but then you're working with this family for, months, potentially over a year, because there's so many, various, variables in there. And so you're trying to individually fit the needs and meet the needs of each person in that family.
Boy, that's great. That's great that you guys work with that. So in that case, I mean, I'm beginning to see the answer to my next set of questions of just how you would get involved. You could go in and be working with a family, and I suppose anything could have brought you in. As you say, a theft, maybe someone was arrested, maybe any kind of call, but you realize that, yeah, and so you could be trying to help them get somebody into the hospital for psychiatric treatment. And have you been involved like, well, how would you compare how would you compare what you do in a situation like that with like the Resolve mobile crisis teams, where they get called specifically for a mental health crisis, and they come out and they're there for an hour or two, they help evaluate what to do, and then they've got more calls to go on, but so they kind of drop and move on. But I guess you guys would be more likely to actually be supporting the family in getting someone into the hospital.
Mhm.
Yeah.
Have you ever had to go along and testify in one of the in-hospital court things where, like within 72 hours, they have to be evaluated, and there's a hearing. And I've been in that situation myself, having to present evidence. So you guys have all been pulled into that.
Yep.
That's tough. So if I just asked any of you, what's the number one failure of current PA law in what you do as it interacts with your work? What would you say? Mental health law in particular. I mean, not touching other things.
That's a really good question.
Yeah, I'll say I usually just kind of roll with the punches.
Okay. Well,
I think it's sometimes hard. So a roadblock I've run into is if I know somebody needs to be psychiatrically evaluated from 911 calls, from situations where I might have not have been on scene because it was 3 a.m.
yeah.
My officer's telling me about it, or a mom's calling me, hey, my daughter's going through this, my son's going through this, and they need that 302. It's sometimes very hard because I don't have that firsthand, I wasn't on scene knowledge.
I see.
So sometimes the 302s might get overturned because I tried to petition it, but I didn't have that first hand interaction with them, and the county doesn't utilize like dispatch. That isn't firsthand knowledge, or we got this 911 call, that doesn't count. So the criteria to get someone into the hospital and to stay in the hospital is sometimes extremely limiting.
It is.
I'd say just to piggyback off that, beyond just the firsthand knowledge, people that know the criteria we have to meet, we're trained to kind of tell, like, yeah, this person's definitely wanting to hurt themselves or someone else in some way, or they can't take care of themselves. but they know we know that, so they're saying all the right things to not be put there. And that can be very, very challenging for us because I can know it all day long as strongly as I know and believe it, but that doesn't get them the help they need if they're not willing to go or
Yeah.
wanting that help and know what to say to not get there. And if I have been fortunate enough not to run into this, but if someone did hurt themselves after my hands were tied, I know that I personally would feel I would just feel terrible. So it sometimes feels like there's not options for people who are savvy in what we have to follow. A lot of times.
We had an experience where when my son got on Medicaid, a case manager gave him advice how to stay out of the hospital. And it wasn't like, get your problem treated. That wasn't it. It was like, don't do this, don't say this, and you'll be good. And I was really annoyed because it didn't help treat his problem. All it did was just, it's just like, make sure you never do anything that shows any sense of harm against yourself. My son's just going, oh, okay. And that was, I'm sure he thought he was helping. But yeah, it just made him more sophisticated about the problem.
Yeah, because a lot of times somebody might go in under a 302, but they know the system well enough that they know when they go see that psychiatrist and sit in front of that doctor, they say, oh no, that person was lying. I
Yeah.
never said that. I meant this,
Right.
and I don't have a plan. I don't have intent.
Right.
And then they're discharged without that mandatory hold. So they just really got a free ride to the hospital, and then they're released in a few hours. And there's nothing we can do. We did our best, we did our
Right.
jobs, we did everything we could for that individual.
That's right.
But they're so ingrained to knowing the system that they work around it.
Or even if a individual goes in as a 201 voluntarily, they tell us that they want to get seen and they want to go down to Western Psych. So obviously we help transport them with one of the officers. We get down
Right.
and they realize the gravity of the situation and they no longer want to. And so now we have to petition for a 302, which can be difficult at that point because, we're having to explain why this person meets criteria and threshold for 302. And then obviously we have to go into that hearing so that they can be held, which we're further trying to explain our case and our reasoning behind why we believe that this person should receive psychiatric attention. And that sometimes just becomes difficult because it's hard to hold someone when they obviously don't want to be held, but obviously they do not possess the capacity to make that decision for themselves. And that's very, very challenging for us.
Right. Right. I found with my son that he really did not expect that he would ever be dangerous. He could tell everybody, and he was telling the truth. He wasn't a violent person. And he would say to me, I'd feel terrible if I hurt somebody. If I saw somebody, wounded and knew that I did it, how could I live with that? And so, that people would believe him, of course, because he was telling the truth. He just didn't have control over, a psychosis that was going to kind of come and go. Yeah, the danger standard is a big part of where I fault Pennsylvania law, and the assisted outpatient treatment law option doesn't really address that, but it does allow for evidence to be heard as to not being able to take care of themselves and moving outside that very strict, clear and present danger criterion that we have now. Have you had cases that were, I don't know, near misses where they almost met the danger standard, but the judge didn't quite buy it? What's that like?
I find it very frustrating, personally. Yeah.
Yeah, it's very frustrating. So I can give you a really good example. Jalen and I actually just worked on a case like this. I petitioned for a 302 based on very clear and present criteria to my officers and my department and the interactions that I had with my individual. Unfortunately, my 302 was denied. And as I'm on the phone with the delegate portraying my case and explaining why this individual desperately needs to go to the hospital, the individual actually ended up in a situation in Jalen's town where they were violent and were actively threatening other individuals. So Jalen and his officer ended up petitioning a 302 at Western Psych because my evidence got denied, but then this individual furthered the
Right.
situation and did become a
Right.
danger. So we could have had this individual in Western Psych 4 hours previously, but because my 302 was denied, they continued to escalate and then did become a harm
Yeah.
Right.
to individuals.
And that individual could have caused harm to the employees of that, establishment. And so I arrived on scene with our sergeant to help de-escalate the situation, to also, sometimes we try to help. I mean, we're like in the business area, so I'm trying to also just help the people who are going into the different businesses around there, and just trying to, just make sure that they were okay, because they witnessed it. And so we're there. We're also trying to, de-escalate this individual, then also get this person into our vehicle so we can transport them to Western Psych. So it's a process, and like Mary said, myself and one of the officers, we had a petition for that 302. We actually had that hearing on this previous Tuesday, and it almost did not get granted, despite. I mean, I think Mary, you guys were dealing with that individual all morning for hours. There were countless witnesses to this individual doing things. Also, myself and other officers from different departments were on scene. So we had so many eyes on this person, and we all observed and witnessed these behaviors. And so, whenever we're going, we're, trying to have that conversation with the defense, obviously that can be challenging as well. And,
Yeah.
luckily we're able to get that 302 petition granted, but it was definitely difficult to do so.
And, the next thing that's frustrating about the way the law is set up is you did all of that. And I think what you won with that is up to a 3-week stay, which often isn't enough when someone has a really ingrained, especially a psychosis problem that's altering their sense of reality. It takes longer than 3 weeks. It can take 3 weeks just to find a medicine that they do well on, instead of, becoming hyper or not being able to sleep or whatever. And so even when you get the best outcome, it's only 3 weeks until they're going to be released. I mean, you have to run into that too.
Mhm.
And I
It's,
think it's hard with medication compliance as well. So for really severe psychosis episodes, the individuals a lot of times believe that there's nothing wrong and that their truth is their truth. And there is nothing anyone can tell them that is going to bring them really back to reality, which creates that situation for medical noncompliance, for medication noncompliance. And then we're really back to square one of something's happened and now we're back in the hospital. And it's just a vicious cycle of hospital, stabilized, out, hospital.
Right.
So it's tough.
Which is a diagnosis in itself. I'm sorry, Alyssa.
Go ahead. You're good.
Well, yeah, it's a diagnosis in itself. A lot of the people we run into, they don't believe, they genuinely do not believe that they have
Right.
a mental concern or illness. And so we're trying to help advocate and empower them to get the help that they need, but they are not able to recognize that. And so I'll say, like, what's challenging at times is, 3 weeks is not enough to help stabilize someone, especially when they're going through psychosis. And I mean, obviously medication takes longer.
It does.
Times 30 days just for it to be able to, properly go into the system to show any type of effects. And so by the time they, come out, IOP is kind of the go-to thing. But sometimes I can't even, my client is not even stable enough for me to be able to, make that appointment for IOP and have those follow-ups, because they did not spend enough time being evaluated and also be seen by professionals.
Back when I was first learning about all this stuff in the wake of our tragedy, I was really shocked to realize that the 21 days, 3-week thing, that magic number is simply a limit that was put when the Medicaid law was first passed in the late 60s. They built that in because at the time, people felt that the state hospitals were just bad places in general. Places where people were being abused, where they were locked in and they shouldn't be. There were a lot of concerns about that. And so they simply built in a funding provision such that if a facility has more than 16 beds, Medicaid will not pay for more than 21 days. And if you think about that, you know, if you have cancer and you can go to a particular cancer hospital, not just the cancer ward of your local hospital, but you're in a city that has a cancer, the Sloan Kettering Cancer Center or something. How weird would it be that just because the facility is specialized, therefore funding is cut off at a certain point? It doesn't make any sense at all, but it came out of the 60s when they didn't yet really have a lot of evidence that these brain behavior illnesses were real. They were thinking these people were just manifesting the family dysfunction. And, you know, that happens too. We've all seen that. We've lived with it. But what changed, there was maybe I'm telling you things you already know, but there was a particular time somebody did a study where I think it was in the 1980s, where they got a lot of people with diagnosed severe mental illness, and they found that their families had home movies when they were kids. And they put together a show of these home movies, and then they got a test group and they had them come in, just ordinary people, watch the movies, and it was a simple question. In each scene, one of these children will go on to develop paranoid schizophrenia or severe bipolar, whatever they had. Who do you think it is? And the shock was that it worked. People could usually tell. It was far more than chance. And they suddenly started going, wait a minute. If this kid was 10 years old and didn't have the illness yet, what are they seeing? And that was when they began to think, wait a minute, maybe the illness has been there for longer and it only became manifest in a way that we can see it clinically manifest later. And that got them thinking, wait a minute, you know, what if this wasn't just that when you were 16 or 17, you started acting out your mother's dysfunction? What if it really was something you already had? And the whole idea that it could be genetic, inborn, and just develop over time started up. So, but the Medicaid laws had been written before all that. And so they definitely had the idea that there were people that were trapped in there because they were just manifesting the family dysfunction. They were trying to rescue them by limiting the amount of time. So it's really a perverse kind of thing because it was based on a scientific misunderstanding. So now we have a thing where I'm not sure, even in the city hospitals that just have a psychiatric wing, and you can bet if they do that, it's topped off at 16 beds because that's a federal magic number. And even there, though, I don't know, can they stay in longer than 3 weeks? Probably not. Probably the 21 days thing has just become custom. And the only time you can get them to stay longer is in state hospital. I was just shocked when I realized that it was as simple as that. Like, wait a minute, what? It's not based on anything medical. Just a prejudice from the 60s. Have you ever had any of your clients that you work with successfully go to a civil commitment in Torrance State Hospital?
Bluntly, the two clients that I've had one client go to Torrance
Okay,
and he is never coming home.
okay,
The court system has said that his mental illness is severe enough that he is a permanent resident of Torrance.
it's where he needed to be. Was he
Yeah.
forensic or civil placement?
Both. It was initially forensic, and then once that his court dates were up, Torrance was like, we in good faith and good standing cannot let him come back to society. So he is a permanent resident.
That's another thing that's built into the forensic thing. all these things are built in, and you don't find them out until you're in there. And they have a certain amount of time that they can restore competency and send someone back. And if it takes too long, then yes, they end up staying. So they sort of have their own 21 days limit. It's just a lot longer. So have either of the other of you had success? And because it's really difficult to get anybody into the state hospital. They've shrunk that tremendously.
Yeah, I mean, it's kind of similar to WIPIC. They go in, they get stabilized enough for them to the staff to visually say like, okay, they're okay, come out, and then we kind of start off at square one at some point. At least in my experiences.
Have you ever been to Torrance?
I haven't.
Okay, I have. It's kind of a shock because it looks like a small college or something. It's like a little college campus, out in the country. Probably most of the fields that used to be used for, people gardening, that they used to grow their own food and stuff, they've sold all that off. But most of the buildings are boarded up. You drive in and you drive around, and basically, yeah, you just pass building after building with plywood on the windows. And it's a really strange feeling knowing how few people are able to get treated longer than 21 days. By going to Torrance, you find out that they've just been shutting it down. In addition to, of course, during my childhood, in the 70s, they were starting to shut down a lot of the psychiatric hospitals. Every decade, another tranche of them got shut down. And this is like the last one they're going to keep. And then they shut buildings of it down. And then they still run a couple buildings, and they've, I think it's basically like leased out to alcohol and drug rehab program. Because, and I remember, again, back when my son was maybe back when he was in the jail waiting for a bed at Torrance, he waited about 7 weeks, which seemed to me just horribly long, but I know now that was really not that bad. But I remember reading something, maybe like, I don't know, it was their website or something, and they said that Torrance has been progressively shut down because there's just no need. And I thought, what do you mean there's no need? And then I learned about that provision in Medicaid, and I began going, oh, because Medicaid, even then, there's got to be a loophole. Anyway, basically, they've made the criteria for hospitalization so difficult that then they could just prove there's just no need. Which is, it's, if you talk to a family, which we all have, talked to families where they have kids who have been arrested and were released, or haven't yet been arrested, but are very disturbed. And they want nothing better than to have their kid go to the Torrance civil side treatment. And they just can't get it because there aren't enough beds. And I don't understand it. There it is. It's what the state has done. Another thing you may not be aware of, in state hospital, the forensic side and the civil side have very different treatment. And I don't know a lot about Torrance's civil side. I need to talk to somebody whose kid has been in both. Maybe that's something I should be looking for an interview. But I did know somebody whose child was in forensic and civil in a different hospital, and she said it was just night and day. Because in the forensic side, they're really just there to restore competency. They're not really there. Nobody talked to my son about what had happened. And it was just, they check in with him, and the medical care was good, but they're not really there to help them, apart from, because I guess if you think about it, if they help them too much, that might sort of tamper with evidence in some way, and they just need to get them competent and get them back to the jail so the justice system can handle it. But it's yeah, anyway, just one of the many problems in the system. So So how would it change things in your work if it was possible to be using this evidence to get a civil order that then would lead to more services for the people? Have you had cases where you're pretty sure that you could present evidence that they're not able to care for themselves safely? That's different from violence. Clear and present danger is one thing. Not able to live safely is another.
I mean,
And
it would be a game changer. Oh, sorry, go ahead, Alyssa.
you're all good. You're all good. I'll pipe in right after you.
I mean, it would be a game changer for like the clients I can think of right off the bat. It's that constant state of psychosis. So they might believe that they don't need water because they have enough water in their body. And then they're not drinking, and then they're extremely malnourished, extremely dehydrated. And that's all because of their active psychosis and their paranoia and their delusions, their hallucinations.
Mhm.
Because sometimes when someone is in their psychosis so heavily, they're not in control anymore. So being able to really put that hand out for them, and really help them along the way, would be a game changer. It would be a lifesaver for a lot of the individuals that this would have worked for if we had this avenue. Because no one needs to have criminal charges stacked up and up, but a lot of times, at least in my understanding, sometimes that's the only way I can get my clients into treatment. Like I've had to have a mind shift change. Like when I was a brand new baby social worker, I was like, no one needs to be arrested. We can do this without the criminal justice system. But the reality is sometimes the only way to get individuals into treatment that they don't want is
Right.
for the criminal justice system to step in.
And that's really where we've set the threshold for involuntary treatment. If it's set at danger, it's going to take criminal charges. Right?
Yeah.
Well, I suppose you can have like a little bit of danger that's clearly danger, but isn't yet criminal. That was what they were telling us. They were saying there's nothing you can do except wait until something happens and hope it's not that bad.
I think one of the flaws I see a lot in our systems is that they are very reactive instead of proactive. And a lot of times I'm seeing places where we can put supports in way earlier. But because no one was hurt or hurt themselves or someone else, then we're not going to put those steps in yet.
Yeah. And I really appreciate that we live in a society that's so reluctant to take away somebody's civil right to refuse treatment. It's easy from my point of view to complain and say the system is broken and all this, but on the other side, I wouldn't want to live in a society where it was easy to put somebody on medication necessarily. It would be good in a few cases, but all the fears that people have, people are often afraid that the government will say they're crazy and put them on sedating medication because they voted for the wrong person. I've heard that one. And the other one is people who are afraid that, like, if you're going through a bitter divorce, your ex will say you're crazy and they'll put you on medicine and then you can't. That's really a fear that a lot of people have. And that's what drives the resistance to changing the criteria so that it's easier. They don't think to themselves, oh, I've seen someone with delusional thinking, and I think this other thing will work. That's not how they're thinking. They're thinking, what would I want protections for me? You know, what if I was just acting a little weird? And so they want it to rise to danger, but yeah, it's a problem.
Because I think there's a fine line between criminalizing mental health and trying to get that person the help that they need, whether they realize it or not. So I think this is like a good avenue to present the information, to have multiple systems involved,
Right.
To safeguard that, so there can't be retaliation, there can't be unjust medications, but there can be medications for individuals who truly need it, and the system has basically failed them
Yeah.
in their
Yeah.
journey.
It's like the system was set up for normal people. I mean, people who don't have a brain disorder. A lot of people who haven't seen it up close don't understand that it's it's not that difficult to tell somebody who genuinely needs help. They have a sense that it might be kind of subtle. Maybe someone could just fake it a little bit. How do you feel about that from what you've seen? If you felt confident that you knew what you were looking at.
Yeah, I mean, I usually do. I mean, I'm a person, and especially as new as a social worker, of course, there are times where I was not as sure, but just experience my schooling, I just kind of, I
Mhm.
feel pretty sure most of the time when I'm looking at something, I'm like, this person just definitely needs help.
Yeah, yeah. I was looking at a list in, where do I have it? That moment when you can't find something that you had open on your desktop. I was looking at a list of the services that they included. It's in that one. Nope. Can't find it. Services that they were suggesting would be part of AOT. And we probably already have some of them involved. I think so some of it they were talking about like trying to find them housing. Some of the, I'm sure you guys have been involved with doing that. Sort of the wraparound services, trying to get people in housing, get them, obviously you can sign them up for Medicaid and things like that if they don't have anything. It seems like the piece that we're missing is what they call an assertive community treatment team act. And I guess that's where somebody goes out into the community and finds people and makes sure that, especially to make sure that they have like a monthly injection or something. Or just, I don't know exactly what. I think an ACT team has a fairly wide range of things that they do to try to increase compliance and care. Do we have anything like that right now in Allegheny County?
Not that I'm aware of.
My knowledge.
Yeah. Have you seen people who are on the current involuntary outpatient treatment order, which is only 90 days? People have to meet the danger standard to get that, but you've probably had people who are on that. In that 90 days, was there any kind of team that could help them meet or they were just told by the court, you have to do this?
I think that's one of the ways I see things fall through is there's not necessarily a designated team or person set out to get them there or ease their anxieties or anything like that. That's a lot of times where we step in. And we're also only one person per jurisdiction. And if no one informs us that that person has that order, we have no idea. So I definitely think that's kind of
So you might not be informed that they have an involuntary treatment order.
yeah. I mean, a lot of times our officers are magistrates. If it's our local jurisdiction, they will. But if
Okay, right.
they're coming out of WIPIC, being told they need to go to outpatient, or if they're in criminal court, being told we're not always involved in that loop of communication.
Right. Right. Can the district magistrates that work in your areas order the involuntary outpatient treatment under current law? Is that something they would handle?
I don't.
So from, go
Go
ahead.
ahead.
You're good. I started first last time.
I don't believe our local like district magistrates can mandate outpatient. They can mandate that someone get a mental health eval and follow the suggestions of that professional. But they can't necessarily force that person into a specific kind of treatment.
Right.
My understanding. You guys might have a different experience.
That's my understanding as well. So my magistrate, Jalen and I share a magistrate. My magistrate will often request a drug and alcohol evaluation and a mental health evaluation and to follow through with those recommendations. Sorry. Oh, I thought I had to sneeze. That's embarrassing. And if they don't follow through,
before this.
so if they don't follow through, yeah, a lot of times it's unfortunate because if they don't follow through with that evaluation and those recommendations and they provide no proof, their case gets sent to the Court of Common Pleas, and then it's completely out of our hands. And then it's the downtown judges that handle that. We try to handle it in-house in the magistrate because I think all of us work really closely with our magistrates. But if that person says no, like screw this, I'm not doing that, they just have to go downtown, and there's not much we can do once
Right.
their case gets downtown.
Yeah, but sometimes with, you know, our magistrate, like Mary said, we share the same one. Sometimes he'll call me and say, "Hey, Jalen, I have this individual. He's in O'Hara Township of O'Hara. You know, I want him to, you know, meet with you for 30 days for you to just see how he's doing, make sure that he's compliant with his treatments." And so I'll contact that person. Normally, when that person is involved in the criminal system, they want to do whatever they can so that, you know, they're not
Yeah.
going and going down that road. And so sometimes they're willing to work with us, but like Mary also said, there are times where they're just like, no, don't want nothing to do with you. I'd rather bite the bullet. And we don't hear back from that person. We don't hear from them at all.
So in a sense, you guys have been involved with doing part of what an assisted outpatient treatment program would be doing, a team would be doing. You've been asked to do the follow-up for 30 days or something. That's interesting. One of the distinctions that they talk about in AOT programs is whether the order is step down or step up. Step down means they're in the hospital, and a condition of release is that they have an AOT order. Step up is they're not in the hospital, and you know, and people tend to resist that because it is restrictive to some extent. And especially if you're very sensitive to that kind of restriction. You know, if a team told me to take my thyroid medicine, that wouldn't bother me. But, you know, their population, it bothers them. But it seems like there is sort of a third way that would have to do with dismissing charges if they go on an AOT order. That has to be something. I mean, would that help clear out a certain amount of cases that are in the lower courts?
That's kind of what we do now, at least my magistrate. You know, if they meet with me I do the same, my magistrate and I have the same kind of partnership. He'll call me up and, you know, let me know the situation and, you know, set up like a 30, 60, 90 days. And if that person, you know, meets with me, is agreeable to some of my suggestions, shows progress, he'll either lessen or dismiss charges based on the situation.
Okay. So, I mean, it really sounds like everyone's sort of working toward this anyway, but without the law, without the legal structure.
Yeah, and I think it is important to note that our services are completely voluntary. So whether a judge can say you have to work with Mary, you have to work with Jalen, you have to work with Alyssa, if that person doesn't want to, we cannot force anyone to work with us. My policy is I usually try 3 times. I try to reach out 3 times, make contact, try to not coax them into meeting with me, but like, hey, like this will help your case out. Like, let's try to do it super easy. But if they are extremely against it and they just don't answer, there is nothing we can do. There's nothing I can do.
Right.
I can't coerce you to talk to me. I can't force you to talk to me. If you don't want my services, if you don't want to talk to me, then that is your choice and you have that autonomy.
I think in Pennsylvania's AOT option, one of the things that's notable is it's not written with a whole lot of force in it. There was a lot of concern when the law was being negotiated about whether you were, you know, people picture somebody being arrested and carried away because they forgot to take a pill. That's how they would put it. And so it seems like even under the AOT law, if somebody is under a civil order to be cooperating with a team and they just refuse and the team works with things and cannot get them, it sounds like what they can do, the most they can do is go back to the original judge who gave the order and ask to have an evaluation done. And then that evaluation might lead to hospitalization. That's really kind of one of the little hangups, but it seems like there are a lot of people that would be helped even if the law didn't have teeth like that. There are some people who just don't want to be helped, period, end of story. But other people, they really probably do want to work with you, and would work with an AOT team, I think. Do you think that that's probably true? Do you think most of the cases of the people that you see probably would work with a team? It's not really voluntarily, but at least cooperatively once mandated. Do you think they would?
Yeah, I mean, most people I come in contact want help of some sort. Like everyone's been saying, you always hit that couple people that are they just don't want it, and that is their right to not want it. But 9 times out of 10, people want that help. So I think people will be willing to work with anyone willing to help them.
Mhm. I totally agree. I think more often than not, most of my clients on my caseload, they sought out that help. Like they wanted that help. Obviously you get you get that occasional person who doesn't want anything from you. They don't want to hear from you or talk to you. But more often, people are receptive to our services.
So where we might not be able to help 100% of them, just having a team that would be doing the kind of follow-up you're doing, but with more of a court mandate, really. It's not criminal, but it is civil order for them. It sounds like you feel that it would help, let's say 9 out of 10 people in that situation would just, okay. I think my son would have. He, you never know what someone's going to do until you do it. But I think given a team, he would have gone ahead and cooperated with them.
Mm-hmm.
Yeah,
And I think,
no, go ahead, Mary.
no, go ahead. You're good.
Well, obviously, if you have a team and this team is working with that person, they can build a rapport. You can establish that relationship. And so,
Right.
I have a couple on my caseload currently where the husband first came to me because he had concerns for his wife who is diagnosed with schizophrenia. However, she doesn't believe that she has any type of mental illness, and so them for months. And she has the diagnosis, but she's not taking her medication. So obviously she was experiencing psychosis. We were able to get her into Western Psych to at least somewhat become stabilized. But then afterwards, when she was discharged, Western Psych said that they wanted her to do IOP, but they didn't take her insurance. And so IOP could not be done. And so now I'm working with them trying to figure out different avenues. And the husband, obviously, that's impacting their marriage, and they're having other with that, mainly because she needs to become stabilized. She essentially needs to just be on her medication, and I do believe that she'll be functioning pretty well. But it's getting her on that medication is very difficult. In my position, in my role, I'm having couples therapy sessions with them. I'm talking to them. I'm trying to empower her, but there's only so much I can do. I like we've said, we're only voluntary.
And to just kind of piggyback off of Jalen, I think the whole wraparound team aspect is really important because we see a lot of housing disparities with individuals who have severe mental illness. So a lot of times that if they're causing a lot of societal disruption, they'll get evicted or they won't be able to handle themselves financially because if you're manic, we know that a symptom of mania is frugal spending of your money. And then they have no money for rent, they get kicked out of their house. So having that really holistic wraparound team that the social worker can talk to the psychiatrist, they can know what medication they're on, to have that open source of communication to really work holistically for that individual is really important. Because I've seen with some of my clients, I've run into roadblocks where they won't sign an ROI. So I might be doing something that the psychiatrist doesn't know, or they might be on one medication and they're talking about side effects and they won't tell me what meds they're on. So I can't really give them a whole guidance. So really that team aspect would be great. Because like we said, the three of us are just one person. We're the only social worker in our department and we work with all cops. So we bounce each other ideas off of each other. Like I'll call up Alyssa or Jalen and be like, hey, like I have this situation, like give me your insights. What do you think? But really having that whole team working with that one individual would be awesome.
Yeah. And I noticed also when I was reading the provisions of the law, at least for the initial evaluation, to determine if this person will have an AOT order, it specifies to be talking to family. Maybe not everyone, but somebody that the person lives with, somebody somebody who's responsible for the person. One of the things that families really have trouble with without that kind of provision, with just the general HIPAA stuff, is that they'll end up that they have a son or brother living with them, and they aren't allowed to know what they're on or if they're taking it or anything. They're not allowed to talk to the doctor, and it's just ridiculous if you're living with somebody. So people have been wanting, and it was interesting to see that the law did have that provision written in, help with the families. Yeah. So let me ask you, I watched a presentation of a health official in New York State last week talking about how their AOT program is going in New York City. And I know it's New York State in general. They started strong. They were the people who first pioneered this back in 1999 with Kendra's law, after Kendra was pushed in front of a subway train. And at first they did a lot with it, but since then, it's been some years since 1999, and they've kind of slipped away a little bit. And I think the pandemic, of course, made everything worse. Psychiatric problems got worse, and there were fewer people on staff of things to take care of it. So he was talking about their recovery from that, and he was asked, what kind of improvement do you see for people who are under an AOT order and working with a team? And he said, before AOT, 96% of the individuals there were hospitalized at some point. Whereas once they were on an AOT order, 36% of them were. Now, I would have liked to hear that that was zero, but I'm wondering, let's say if you had 25 people that you were aware of that were under AOT orders, and instead of 25 of them having to meet hospital criteria, only 9 of them did. Would you consider that worth the program? I mean, in your work, how much of a difference would that make?
I mean, I think 9 out of 25 is pretty good. I don't know any intervention's ever going to be 100%.
Yeah,
Yeah.
mental health it's like any science, it's not an exact science.
Yeah.
I don't think you could ever have anything that's 100% effective, because everyone's brains and everyone themselves is so unique.
Right.
And there are so many different situations that can trigger something. So I would say 9 out of 25 is very successful. I mean, even just comparing it to substance use. Like, I know one individual who went to rehab 27 times before he was eventually stable and clean, and now he's 10 years clean, but it took him 27 times to get there. So it's not a one shot, like,
Right.
you're good for life now. It's a constant process. So I agree with Alyssa that 9 out of 25 isn't bad.
Yeah. For the arrest rate before AOT orders, a quarter of them were getting arrested. After AOT orders, 8%. So that's your 2 out of 25. That would really make an impact in police work, obviously. No, I guess it was not arrested. It was actually going to jail. But yeah. Yeah, again, it's not zero, but it's 26% down to 8% is a pretty significant drop. So, well, I guess we'll wrap up. Do you have anything else you want to leave the county and the public with? Just my word to them is, please go ahead and opt in on the AOT law. Let's start working with this and having another tool. Do you have anything you want to add?
I think just further conversations needs to happen. I think that obviously discussing this and having this panel and just holding these conversations, I think is very important to spread AOT, and then also just trying to figure out that due process and what it looks like. So I just think just having those conversations, I think is very important.
Right.
And I
Right.
think this is a great start. So thank you for having us, Ruth.
Yeah.
Yes, thank you for coming. I'm going to make sure that people in the Department of Health get to watch this and I want to do this again, especially if there's some other angle that comes up. I would love to have some of you back again and we'll just keep talking about this. So thank you, Mary and Alyssa and Jalen, and talk to you later.
Yeah, thank you.
Okay, good
Good night,
night.
guys.
Good night.